The title, I don't know if it is appropriate or not, but I'm sure that microsurgery of the extradural space and structures is inevitable now. Why? I was confronted with the problems at the lateral skull base dural border, which is not just one step more laterally, as many big names were convinced. There are new territories. And regions of critical conflicts we may be confronted are at the region of the anterior clinoid process, at the posterior clinoid process, cavernous sinus, and petrous bone. And for that reason, it was necessary to study in details paracellular ICA, cranial nerves, triangular entry areas, venous compartments of those regions. Anterior clinoid process presents space limitation. This was actually the trigger. I was operating an aneurysm at this region and I could not fix it. Then I said I have to get rid of this bony protrusion. I got a drill from dentist with terrible torque, and it was not diamond drill, it was cutting drill, so it was very dangerous, but useful to start the studies at the laboratory. And I was sure and convinced that anterior clinoid process, which is here at the border, is preventing us to get out from the intradural space to the extradural in the region of the anterior clinoid process and cavernous sinus and so on. Here you see the removed anterior clinoid process facing mucous membrane of the sphenoid sinus, and here over proximal ring around the carotid, you see the carotid in the cavernous sinus, and you see intradural space, because many neurosurgeons were famous and good, excellent in intradural anatomy, including, of course, Roton, Donaghy, Yashargil, Kersey, and so on. But no one was not actually studying extradural so far. And we were forced by the practical cases to go over, to be aware, to be familiar with the extradural, which is over this region, and intradural. So you can be safer in one side of the wall if you know what is going on the other side of the wall. And this is an example, an aneurysm, large, and you can only safely, I would like to underline, safely exclude it if you remove the anterior clinoid process. You gain space and you can preserve the carotid. So it's like here. You see intradural space and extradural. So we just need to cut the dura and then we can follow the carotid from extradural to the intradural. Another similar case where we remove the anterior clinoid process to be able and to get space to put the clips. In giant aneurysms like this, at the adjacent to the dura, you see it was 5 centimeters actually in diameter, and we were able to preserve the carotid and to remove the aneurysm. But thanks to the getting space. Anterior clinoid process varieties. My colleagues, they are calling it variety. There are different varieties, different connections of ACP to the base. Sometimes it forms the ring, the bony ring around the carotid. Sometimes it is hypertrophy of the anterior clinoid. Sometimes it is erosion, and sometimes it is pneumatized. So it is not all the same. The clinoid process is different. Here we see the giant and enlarged hypertrophic. It is not only to remove it and be happy, to remove it safely, not to damage the optic nerve, not to damage the carotid artery, which is underneath. And it is much more difficult when the anterior clinoid is normal. And here you see the removal. Then you might be confronted with a situation like this where the anterior clinoid is missing. Why? Because there was a trigeminal neurinoma on the first branch of the trigeminal, which was compressing over the bone, and the bone disappeared. Here it is normal. Why? If you are aware, if you are in command of the anatomy, and you know how the tumor spread, then you will understand why it is pushing the V1 and the third nerve against the floor, against the optic canal, against the other structures. And then you can safely remove it. The last variation is pneumatization of the anterior clinoid process, like here. And here you cannot bluntly remove the anterior clinoid process because you will create a tunnel, and then CSF fluid will get out of the nose. And my generation, we are still with the chip in our brain that the fistula is a severe and serious complication. Anterior clinoid process resection, extradural or intradural. This is an everlasting conflict, and I do not understand why. We somehow favor the extradural removal of the anterior clinoid process and visualizing the structures extradurally, the ICA loop, optic nerve, and proximal ring and lateral wall of the cavernous sinus. So when we remove it from extradural side, we prepare and provide enough space to go anteriorly to the pathology, either vascular or tumorous. And then it is much easier to deal with the pathology. Now we have to be aware of the cellar and paracellar compartments. And we have to keep in mind how is the position of the ICA intradurally, how is the position of ICA extradurally, how the coverings of the anterior clinoid process are continually running toward the lateral wall of the cella. And then we know what is on one side and what is on the other side. And we not only understand the anatomy, we can also understand the physiology, how the hormones from the pituitary gland are traveling along the venous flow through the fenestra to the cavernous sinus, and so may spread also the tumor, one or the other side. Internal carotid artery coursing throughout the skull base and control of blood flow through it. For this, we need to study the bony structures and the coverings and the structures of the cavernous sinus, and of course, both posterior and anterior clinoid, and then we can put the carotid in it. Here from the side, you see that the coursing is making loops, posterior, somewhere here lateral, here the medial, and here anterior. I don't orient myself enough with C4, C5, and so on. I prefer natural descriptions of the coursing of the carotid. And here is the illustrator who put very nicely, this is the petrous portion of the carotid. This is the intracavernous portion of the carotid. This is underclinoid portion, and then intradural. Intradural and this portion are horizontal. And this is very important to have this concept. Then you can put yourself imaginary inside the cavernous sinus, and you look around and you can see the structures around you. But you have to understand also that the skull base ICA is not just running through the cavernous sinus. It is heading, it is looping, it is spinning. We have no time to go into this discussion. What looping means, what spinning means, spinning of the blood inside the carotid and causing the aneurysms or other physiological functions. Of course, when you go more laterally, then you, after removal of the anterior clinoid, you can study the course of third, the fourth, and the sixth nerve, which is inside the cavernous sinus, and also the sympathetic nerves. The fifth nerve is lifted over away, and this is the lateral ring. So they are very, very precise, very definite, very firm anatomical frontiers or structures you can use for your orientation. For instance, here, when the cavernous sinus is completely open and the third, fourth, and fifth nerves are away, then you can follow the sixth nerve, which is adjacent to the carotid and which is always running laterally to the inferolateral trunk. So it helps you to orient yourself in the cavernous sinus, and in particular when this space is filled with the pathology. You can go further. We found at one specimen small aneurysm, and this opened was our eye opener, how the aneurysm grows and what does it cause. For instance, you can see here the sympathetic nerves. You can see here the sixth nerve coursing over, and what happens when it grows? It will grow, it will cause the sixth nerve palsy. And then the sympathetic nerves, when the pathology grows further, will be torn. And the symptomatology from the sixth nerve will disappear. And so I was able to understand what happened to this young girl. She was 16 when parents brought her to us. They said when she was 3, she had sixth nerve palsy. And then with very successful physiotherapy, it went away. No, it didn't. The sympathetic fibers were torn, and then the sixth nerve glide at the site of the tumor, and until 16 years, when the tumor grow further and compress the nerve, the physiotherapy was not effective anymore. Now, anterior clinoid process resection, regarding the varieties of it, and according to the adjacent conflicting pathology, vascular or tumorous. Of course, we have to be aware what is underneath. It's easy to remove all this portion, but it is not so easy to go inside and along the cavernous sinus. But when you remove the sphenoid wing, when you remove the anterior clinoid from extradural space, you devascularize the tumor and you much easier remove later on the tumor. Of course, it also helps you in such big pathologies, and you can remove it completely. Necessity of resection of the posterior clinoid process in surgery of the posterior clinoid process and upper clival meningiomas. When you remove this from other side, from extradural side, you can help a lot to the surgery, and you can remove the posterior clinoid process meningioma completely. You see, the brain is intact, the tumor is missing. Also, superior or upper clival meningioma can be removed completely, but only with the removal of the anterior clinoid process. This is a case, this aneurysm was treated with by endovascular people. They could not exclude it. I operated this case with Yashargil in his operating theater, and we were able, by gaining the space with removal of the anterior clinoid, to get nice approach to this part and then to resect the aneurysm and to fix it. So anterior clinoid is our obstruction while we are working in this region, either only intradurally or intradurally and extradurally. But to be sure that we can manage if something happened to the artery, we have to be prepared, and we have to visualize the posterior loop of the ICA in the petrous bone behind the Gasserian ganglion and V3 and medially to the middle foramen spinosum. Of course, by knowing the anatomy at the anterior clinoid process, at the posterior clinoid process, at the apex of the pyramid, then we can control the blood flow through the carotid artery, and we can deal with this huge tumor, and we can remove it. We see that this carotid is compressed, as you see here. But we have to understand that the tumor did interrupt also the adventitia, And if we go too far with peeling off the tumor from such an artery, we may cause a rupture of the artery during surgery or after surgery, which is always very difficult or even catastrophic. We can also replace this diseased part, but you have to be sure that the short high flow graft will work. This is even more important when we have a no ACA1 on the site of the tumor. And you are forced to deal with the extradural structures here with the cavernous sinus when you have the aneurysm which is inside it. And you have to know the anatomy. There is no escape. You cannot say, okay, I will fix it somehow. How you will fix it? Will you close the artery? But you can, with the knowledge of the anatomy, you can resect the aneurysm, you can reconstruct the artery in the cavernous sinus and intradurally. Or this case, the cavernous sinus is completely filled with the vascular pathology, huge aneurysm. After reconstruction of it, then you have a normal or almost normal ICA and preserved ophthalmic. I hope that you will agree with me that this cannot be treated endovascularly. With all due respect to the endovascular treatment, but surgery should not be completely ruled out of vascular surgery. As here, we can only go in, we find the distal stump, we find the proximal stump, and then we put the graft in between. Or in cases of injury, you cannot also pull this nail with the endovascular technique. You have to go in and you have to reconstruct it, and then the flow is preserved. Tentorial edge and transition of the cranial nerves from intradural to extradural space. The dural ring, which is on the lateral side, and then continue to the tentorial edge, shows us what is inside, what is extradurally. And so you can follow very nicely the course of the third nerve, where it comes in, through the tentorial edge and then intradurally. And then also the fourth nerve, which is very close to the V1. And then we have these triangles. Apex of the petrous bone and the inner auditory canal with the 7th and 8th nerve. We are at the posterior side, on the right side, posterior side of the gasserion ganglion. We remove the petrous bone, we explore the ICA posterior loop, and then we drill further down toward the posterior fossa, and we are aware where the inner auditory canal is. We cut the dura on the posterior fossa side, and we open, and we are in the inner auditory canal, as was many, many years practiced by Japanese otorhinolaryngologist Shiobara. Resection of the apex of the pyramid and safe corridor from the middle cranial fossa to the posterior cranial fossa. This is important and useful at the tumors at this region. So we see here the drainage from the cavernous sinus. We see here the posterior loop of the ICA. We see here the superior petrosinus, where the petrous vein is coming somewhere here, and here the other drainage. So, but we see here the free bone, and then we can enter this region from the posterior lateral side. We can enter this region, and we are posterior to the 5th nerve, anterior to the 7th and 8th, inner of the inner auditory canal. So, and here is the, where is this now? Where's the 6th nerve? Yeah, don't. Here's the 6th nerve, you see, and you go through this corridor, as it is shown here. Superior petrosinus. The 4th nerve is there. The 6th nerve is down here. So, and the apex of the petrous bone in front of the inner auditory canal and behind the petroclinoid ligament can be completely removed like this. And you are safe. And you come from the middle fossa to the posterior fossa. Now, petroclaval and Dorello's canal or space meningiomas, like this, when you go through the petrous bone, then you can remove this tumor completely. Like you can see here, bulging into the bones, and here after surgery. But we are on the right side. This is V3. This is ICA posterior loop, Gasserion ganglion, and the fifth nerve, the root of the 5th nerve. We remove the tumor from posterior side, but the job is not yet finished. We have to, when we remove the apex, we can transpose the root of the 5th nerve posteriorly, and we come anteriorly to the 5th nerve, and then we can remove the tumor, and we visualize the brainstem, we visualize the origin of the 6th nerve, we follow the 6th nerve all the way to the cavernous sinus. Now the tumor is completely eradicated. But we have to be aware, again through the anatomy studies, that the 6th nerve might not be just one fascicle. It might be composed from several fascicles. So you have to be aware of this. This is carotid underneath. Now we come to the most difficult and most tricky part, to the corridor to the basilar artery tip. Removing the sphenoid wing, anterior clinoid process, posterior clinoid process, and then through this trajectory coming down to the basilar artery tip. Why this is so important? If you go medially from the carotid, we are on the right side, optic nerve here, you see here the perforators, thalamus striates. If you push the carotid laterally, you stretch the perforators and they may occlude afterwards, and you will have a bleeding in the midbrain. But if you go laterally, you push the carotid medially, and then you relax the perforators. You visualize the PCP. ACP was here, is removed already, The third nerve is laterally. So you have all the structures in front of you. This is the specimen. Then you visualize the posterior clanoid process. You can remove this bone. Pituitary body is here. Intradural carotid here. Intradural, ICA in the cavernous sinus, and the third nerve here. You remove it from extradural side. And then you visualize the basilar artery and the bifurcation, and you have enough space to deal with vascular pathology or to deal with tumors. This is a case. Look, perforators are preserved. The patient is completely normal after surgery. I have to mention history a bit. Duke Sampson mentioned in his publication with Hodosh about the basilar tip aneurysms that they were aware of the possibility of removal of the posterior clanoid process, but they thought it was too dangerous. Then we were studying this, and we said if we deal with this carefully, we may do it, and we did it. Leonard Mallis, I visited him in '82, and he said, I don't believe you. You cannot go into the cavernous sinus. But I showed him what I did and what we did in our lab and in the clinical practice. But 3 years later in Japan, when I was under attack again from good colleagues who didn't do these cases, he said, they asked me, how you do it? And Mary said, I will answer. And then he told the story, how he did not believe, and now he is able to remove much more tumors from the cavernous sinus. And finally, Yashargil, who wrote the foreword in my book from '89, was in the department when I was asked at his department to treat an aneurysm at basilar tip, and I said I cannot accept this case and I cannot operate without asking professor. And then professor came and he said, oh, no, this aneurysm cannot be operated. Only a fool can operate. And then he said, oh, just him, like me. The family was on the other side. He can operate it. And I said, professor, why don't do it together? I will do the approach and you will do the aneurysm. So I did the removal of the anterior clanoid, posterior clanoid, and visualized the whole region. Then he continued and he fixed with ease the aneurysm. After surgery, I mean, already during the surgery, he said, you know, I did not believe to you, but now you convinced me.
Vinko, we are with the time.
Late, we are late, yes, just conclusion. Surgery, so-called surgery in the lab prior to central skull base, live, real surgery for me is a must. Thank you very much.